चलो अब हम स्टार्ट करते हैं. बिफोर दैट यस, पहले हम जो प्रथा है उसको हम कंप्लीट कर लेते हैं. यू हैव टू फॉलो मी ऑन टेलीग्राम, यू हैव टू फॉलो मी ऑन इंस्टाग्राम एंड योर फीडबैक्स विल बी मच मच अप्रिशिएटेड. बताइएगा हाउ यू आर फाइंडिंग माई वीडियोज विच आई एम पुटिंग ऑन माई यूट्यूब चैनल. ऑल राइट, नाउ स्टार्टिंग विद द वेरी फर्स्ट चैप्टर विच इज दैट ऑफ द ऑर्बिट. यस, लेट मी नो व्हाट इज दिस. कैन यू सी समथिंग हैंगिंग? व्हाट इज दिस हैंगिंग थिंग? This is a typical sign that you call as teardrop sign. Yes, so this is teardrop sign and it is seen in blowout fracture of the orbit, in which there is herniation of the intraorbital contents through the fractured inferior wall of the orbit. Yes, okay, so this is teardrop sign seen in blowout fracture of the inferior wall of the orbit, and it is seen in which trauma? Blunt trauma, penetrating trauma. It is seen in blunt trauma. All right, what is this? Can you appreciate that this is a scale which measures the extent of proptosis? But if you are measuring proptosis in adults, you use an exophthalmometer, which is this one. The name of that exophthalmometer is Hertel's exophthalmometer. Yes, and if you are using the scale which is meant for children, you call it as which exophthalmometer? It is Ludy's exophthalmometer. So I have given you two important MCQs. This is your previous year AIMS question. Hertel's exophthalmometer was asked in your INICET recent exam. Okay, what is this? This is which test? This is your Navziger test. What is Navziger test? So you ask the patient to look towards the ceiling and you stand behind the patient and you look out for the relative position of the eyeball, based on which you can tell whether the patient is having proptosis or no proptosis. So here you can see that there is difference in the position of the eyeball. So it is used actually for qualitative assessment of proptosis, while in this exophthalmometer you actually measure the extent of exophthalmos. So this is quantitative test. But as he always say, अगर आपने पेशेंट नहीं देखा तो आपने क्या देखा? तो इसलिए आई एम जस्ट क्विकली गोइंग टू शो यू द पेशेंट. यस, ओपन ही नहीं हो रहा है. अब ये ओपन हो गया है मेरा फोल्डर. तो ये देखिए, आपको एक बार Navziger टेस्ट थोड़ा सा बता देता हूं, so that it becomes easy for you to appreciate. So what is happening here? So I am holding the camera behind the patient as if I am standing behind the patient. I am looking for relative position of the eyeball. So this is your Navziger test. But if you stand not in back of the patient but in front of the patient, you ask the patient to look towards the ceiling. So this is known as worm's eye view. So both are qualitative tests for the assessment of proptosis. So one is worms if you are standing in front of the patient, and another is your Navziger test. Done? Okay. Next is, what is this? So this is a case with periorbital edema, conjunctival chemosis, mid-dilated non-reacting pupil. Guys, please understand that I am focusing only on the images, so you need to have full focus on the images. Side by side थोड़ा बहुत मैं आपको related history दूंगा. I'll be providing you with a little bit of associated history as well, so that our maximum PYQs, PYTs are touched, है ना? So this is a typical case of what? Orbital cellulitis. Orbital cellulitis. चलो, can you tell me which is the most common organism associated with orbital cellulitis? It is Staph aureus. Which is the most common sinus associated with orbital cellulitis? Ethmoid sinus. Okay, two more MCQs down. Okay, now what is this? This is the test which you use to differentiate between paralytic squint and restrictive squint. What is the name of the test? This is forced duction test. So this is forced duction test. So what is forced duction test? I give you an example. So suppose the patient has come to you with right hypotropia. Yes, now you are confused whether there is paralysis of the right superior rectus or there is restriction of the right inferior rectus, because if there is restriction of the right inferior rectus, it will not allow the eyeball to go upwards, and as a result the patient will come to you with right hypotropia. Yes, if there is paralysis of the right superior rectus, even then the superior rectus will not be able to pull it up, so the eyeball will go down, right hypotropia. Now what you do, you take a forceps, put it on the superior limbal conjunctiva and try to move the eyeball upwards. If you are able to move the eyeball upwards, that actually tells you that it is a case of right superior rectus paralysis. If you are not able to move the eyeball upwards, that actually tells you that something is holding the eyeball from below, right inferior rectus restriction. So that is how you differentiate. So in this very patient, you can see that the patient is having left exotropia. So I am holding the limbal conjunctiva on the nasal side and I try to move the eyeball here. If it is moved, then actually it will tell me that it is a case of left medial rectus paralysis. If it is not moved, then actually it will be due to the restriction of the lateral rectus from this side. So the same concept which I just told you. So this is force duction. Force means zabardasti, duction means movement test. So you are forcefully moving the eyeball. Okay, now switching over to the images of the second chapter, which is your lens and its disease. Can you tell me most common congenital cataract? What is this? Yes, what is this? What is this? So this is your blue dot cataract. Most common congenital cataract is blue dot cataract. But the most common congenital cataract which is associated with loss of vision, boys and girls, is your lamellar, or one and the same thing, Sita Gita, not Sita Gita, Sita and Sita only, because it's one and the same thing. Sita Gita, two different people, na? Okay. Lamellar or zonular cataract. You can call it as lamellar cataract, you can call it as zonular cataract. Your previous year question, in lamellar or zonular cataract, you are typically going to see, what are these? These are known as riders. You are typically going to see riders at the periphery in lamellar or zonular cataract. Okay. What is this? Congenital cataract. White pupillary reflex. Yes, it is seen in white pupillary reflex. What is that known as? It is, boys and girls, leukocoria. Now, can you tell me if there is a case of congenital cataract, unilateral case or bilateral case, which case you will operate early as an ophthalmologist? बताइए, unilateral case को करेंगे, bilateral case को करेंगे. You will operate unilateral case first to prevent what? To prevent amblyopia. Unilateral case is operated first. This line which I just told you was one of the options in your recent INICET exam. So, I am just trying to touch all the important, PYQs and PYTs around the images. Okay. Now what is this? क्या लग रहा है ये? WhatsApp तो बहुत करते होंगे आप. तो WhatsApp में एक ऐसी स्माइली भी देखी होगी आपने. अब अपना WhatsApp खोलिए और वहां पे टाइप करिए SNOW. फिर जो आएगा मुझे बता देना. आपके पास ऐसी स्माइली आएगी तो इसका मतलब क्या है? This is your snowflake cataract and this is the most common type 1 diabetes mellitus cataract. It is seen in most commonly in type 1 diabetic mellitus. And even if I talk about most specific diabetic mellitus associated cataract, that will also be your snowflake cataract. But if I may ask you which is the most common cataract associated with diabetic mellitus, that will be your which cataract? That will be your early senile cataract. Why? Because overall, if I talk about diabetes, type 2 is more common than type 1 and type 2 causes more commonly early senile cataract. So overall, it is the early senile cataract which is most common. Yes? Okay. Now, what is this? Christmas tree cataract is seen in which condition? It is seen in myotonic dystrophy. It is seen in myotonic dystrophy. Okay, done. All right. So this is oil drop cataract. Oil drop cataract is seen in which condition? It is seen in galactosemia and it is the only reversible cataract. Which is the reversible cataract? It is galactosemia. It is only reversible cataract. Okay. Now next cataract if I am talking of is your snowflake cataract. Snowflake cataract is typically seen in Wilson's disease. It is typically seen in Wilson's disease. It is snowflake cataract. And one thing you need to take care of is that in Wilson's disease, there is copper deposition. There is copper deposition where? In the Descemet's membrane of cornea. There is copper deposition in the Descemet's membrane of cornea and that is forming a ring. That ring is your KF ring. That is your KF ring, Kayser-Fleischer ring, and this ring is reversible. It actually tells you about the response to the treatment, and this is also one of the option in your previous year INICET question. So KF ring actually tells you the response to therapy. If the patient is responding good to the therapy, which is D-penicillamine, which you will give, है ना, chelating agent, and when the copper levels will go down in the blood, in serum copper levels will go down, so you will see that there will be reversal or regression of your KF ring. All right, so what is this disease? This is your Fabry's disease, and typically cataract you see in spoke wheel cataract. So it will be spoke wheel cataract. Now I recently received a message from one of the student who said, sir, how to differentiate between spoke wheel cataract and vortex keratopathy? So vortex keratopathy happens to be in the cornea. Spoke wheel cataract will be there in the lens, but on 2D view you are not able to appreciate whether it is vortex keratopathy or spoke wheel cataract. Check out the spokes. So if it is in the cornea, it will extend beyond the border of the iris. Yes, if it is on the cornea, it will extend, but if it is in the lens, so it will not be seen because the iris will be covering that part of the lens where there will be spoke wheel appearance. Yes, so this is how you will make out. Okay, so what is this? This is your traumatic cataract, which is rosette cataract. It is seen in which form of trauma? It is seen in blunt trauma, and typically it is your posterior cortical cataract. It is seen in posterior cortical cataract. Mind you, if I am talking of penetrating trauma, it will be anterior cortical, because when the foreign body will penetrate cornea, it is going to hit the lens. Which part of the lens will receive the foreign body first? Anterior cortex or posterior cortex, boys and girls? It will be anterior cortex, hence anterior cortical cataract. Penetrating trauma, blunt trauma, posterior cortical form of cataract. What is this? So there is history of blunt trauma to the eye. What is this? ... What is this? This is typically Washious ring. What is Washious ring? When there is blunt trauma to the eye, there is compression of the iris on the anterior lens capsule, due to which there is pigment dispersion on the anterior lens capsule, which will lead to formation of a small ring. You call it as Washious ring. Okay, wonderful. What is this? Spot diagnosis. Yes, this is your cortical cataract. Can you appreciate the opacities at the periphery while there is a typical central clearing? It is cortical cataract. Now what is this? Can you appreciate the opacity here? Can you appreciate the haziness in the center? Yes, so this is your nuclear cataract. This is your nuclear cataract. Another spot diagnosis. What is this? This is your posterior subcapsular cataract. It may be a little difficult to appreciate because it is a 2D image and the light is coming from here. So this is actually what? This is actually the space between lens and the posterior capsule. This is actually posterior capsule. So you can see that there is opacity at the posterior capsule. So this is your posterior subcapsular cataract. Posterior subcapsular cataract is the cataract which is present between the posterior surface of the lens and posterior capsule. Okay. Now what is this? Now what is this? So which step is being done here? यहाँ पे हम कौन सा step कर रहे हैं? So this step is your hydrodissection. This step is your hydrodissection. You take the cannula, place it between the rim of the anterior capsule and the lens. As the water will flow through the rim of the anterior capsule and the lens, so it will go through and through, and as a result it is going to separate the lens from its around lying capsule. It will create a positive pressure here, and this lens will come into the anterior chamber in case of small incision cataract surgery, yes, which is a form of ECC, or if you are doing phaco, you inject water, it will still remain inside the capsular bag, but it will be separated from its around lying capsule. So this is your hydrodissection. What is this? This is your phaco probe. Phaco probe is doing phaco emulsification. What is the length of incision in your phaco emulsification? It is 2.8 to 3.2 millimeter. If I may ask you, what is the length of incision in extracapsular cataract extraction, which is conventional? It is 10 to 11 millimeter. What is the length of incision in manual small incision cataract surgery, which is nothing but a modification of ECC only? It is 5 to 6 mm. These three are very important for you guys. Okay, now what is this? This is your most common late complication of cataract surgery. What you call it as? You call it as posterior capsular opacity. Posterior capsular opacity, or the other name is after cataract, or the other name is after cataract. So it can be of two types. One is Elschnig pearls, another is Sommering ring. Yes, so here you can see, can you see the small pearly like thing which is seen in the lens? Yes, small pearly like thing. So this is known as Elschnig pearls. After cataract type is your, I am writing it here, Elschnig pearls. Elschnig pearls. Done. Okay, so this is your Elschnig pearls. And what will be the treatment? If you know, I told you that I am going to touch the round line points as well. So treatment is posterior capsulotomy. You go on for laser posterior capsulotomy. Posterior capsulotomy. And which laser do you use? ND-YAG laser is used. ND-YAG laser is used. And what is the wavelength of ND-YAG laser? 1064 nanometer. So these are few terms. What is this spot diagnosis? Can you see the anterior lens which is, you know, kind of forming a cone in the center? So this is known as lenticonus. Which lenticonus? I told you, anterior part of the lens. So this is your anterior lenticonus. If it is like this, if it is like this, so this is your posterior lenticonus. Posterior lenticonus. Okay, all right. Now coming over to the third chapter, which is the chapter of uvea. Okay, what is this? What are these dot dots that you are seeing? Earliest diagnostic feature of anterior uveitis. No, it's not proteins in the anterior chamber. No, it's not KPs in the anterior chamber. It is actually cells in the anterior chamber. And of course, I'll not be able to show you all the associated videos that I show in the class, but some videos which I feel will help you remember the important points throughout your exam and even after that, I'm definitely going to show you. One of those videos is the cells in the anterior chamber. So check out the cells in the anterior chamber. You are actually going to appreciate the cells which are present in the anterior chamber. Now I'm going to increase the magnification of the slit lamp. I took the phone and just put it at the viewing area of the slit lamp. Now you are going to appreciate. Yes, just give me a second. Yes, now are you able to appreciate the cells rotating in the anterior chamber? So this is the earliest diagnostic feature of anterior uveitis. What is the other name of anterior uveitis? It is your iridocyclitis. ठीक है जी, इसको हम iridocyclitis भी बोलते हैं मतलब, अरे ये क्या हो गया? Okay, so yes, cells in the anterior chamber. What is this? This is your KPs. Which KPs? Can you see the large size of the KPs? So these are your mutton fat KPs, and they are forming a typical triangle. What is the name of this triangle? Arl's triangle. Yes, Arl's triangle. Don't confuse Arl's triangle with that of Arl's triangle. We have discussed it later. Okay, mutton fat KPs are seen in which form of anterior uveitis? Granulomatous anterior uveitis. Yes, granulomatous anterior uveitis. Okay, which is this pupil? This is irregular non-reacting small pupil. You call it as festooned pupil. It is seen. Why? It is seen due to presence of posterior synecdoche. If there is posterior synecdoche, you put a drop of mydriatic agent. Where there is synecdoche, it will not dilate, otherwise it is going to dilate. So it is going to give a zigzag irregular appearance to the pupil. So you call it as festooned pupil. Okay, what is this? What is your diagnosis? This is your pizza pie retinopathy. This is your pizza pie retinopathy, and this is typically seen in one disease, that is your cytomegalovirus retinitis. Your previous year AIMS question, CMV retinitis. What is the treatment of CMV retinitis? Now this is your FMG previous year question. The treatment is ganciclovir. So I have covered 3 MCQs. One is your spot diagnosis, which is pizza pie retinopathy or tomato ketchup retina appearance, and the causative factor. Second question, CMV retinitis. Third, what is the treatment? It is ganciclovir. Okay, what is this image now? This image is your headlight in fog appearance. I repeat, headlight in fog appearance. It is seen in which condition? toxoplasma. So it is seen in toxoplasma. Chorioretinitis means posterior uveitis, toxoplasma infection. Okay, now coming on to the next chapter, which is that of glaucoma. What is this? What is this technique? This is your typical applanation tonometry, and this is gold standard. Gold for gold, applanation tonometry. It is Goldman's applanation tonometry. Goldman's applanation tonometry. It is gold standard. Okay. Next is, so this person is checking his own IOP, that is self tonometry, and the tonometer which is used is rebound tonometer. Okay. Now focus on this image. Can you tell me which side is this? So please, first you need to understand, whenever I am seeing the perimetric chart, if this is the perimetric chart, I am seeing this. So I'll consider as if it's my own visual field, and you know the optic nerve head lies onto the nasal side, while its corresponding blind spot will be on the temporal side, you know, है ना? And this is the area of the blind spot. Now you know that blind spot will always be on the temporal side. Here the blind spot is on the left side. So if it is on the left side, so the left side will be temporal of the left eye or of the right eye? Of the left eye, na? So this is your left eye. In simple terms, wherever the blind spot is lying, that is the side of the eye. If blind spot is lying on the left side, so it is left eye perimetric chart. If blind spot is lying on the right side, it is right eye perimetric chart. Okay, identify the side. I have already told you it is left side. Okay, what is this? What is this? This is also your previous year question. So you can see that there is ground glass appearance. There is ground glass appearance of the cornea. Yes. And what is this? This is Harb's striae. What is Harb's striae? Harb's striae is actually tears in the Descemet's membrane. It is tears in the Descemet's membrane, typically seen in congenital glaucoma. So this is a case of your congenital glaucoma. Now what is the treatment of choice in congenital glaucoma? Surgery of choice is goniotomy. So you can see that under gonioscopic view, this is your direct gonioscope. Yes, this is your direct gonioscope. Under gonioscopic view, you are actually cutting the area of Barkan's membrane, right? I'm not going into that much of that. One thing which I want to tell you in congenital glaucoma that you should remember is Harb's striae. Also there is presence of bullseye, that is known as boophthalmos. Yes, boophthalmos. Boo means bulls, phthalmos means eye, means large ox like eye. जैसे ox की, cow की या bull की जैसे eye होती है, ठीक है? All right, now next is, what is this? So you can see that there is difference in the iris of the two eyes. Yes, iris hyperpigmentation is there, and you can see the size of the eyelashes are increased. Trichomegaly. Which drug can cause this side effect? It is prostaglandin analogs. And do you know prostaglandin analogs is drug of choice for primary open angle glaucoma, primary angle closure glaucoma, and normotensive glaucoma. This is also your recently asked INICET exam question. Okay, now what is this? So there is separation of the circular muscle and the longitudinal muscle of the ciliary body. What is this known as? So it is also the recent exam question. It was asked, separation of circular and longitudinal muscle of the ciliary body is known as. So the answer is pretty straightforward, not safe forward, straightforward. Angle recession. So this is angle recession when there is separation of the two layers of the muscle of the ciliary body. Yes, don't confuse angle recession with that of the tearing up of the iris from its root such that it is forming a D-shaped pupil. This is known as iridodialysis. This is known as iridodialysis. It is seen in which condition? Trauma. Even angle recession can be seen in trauma. Okay, what is this? Can you appreciate the transillumination slit defects? Why is it so? It is because of so see, so normal iris is like this. Yes, anterior, posterior. Now what happens in some patient, instead of being like this, so it is like convex anteriorly. This is normal position of the iris. There is a slight convexity, but in some patients it becomes concave anteriorly. If it becomes concave anteriorly, when it dilates, when it constricts, the pupil dilates, pupil constricts. So the posterior part of the iris constantly keeps on rubbing over the lens and its zonules. As a result, there is pigment dispersion in the anterior chamber, and by examining through the slit lamp, you are actually going to see transillumination slit defects. Yes, and this is known as pigmentary glaucoma. It is pigmentary glaucoma. Yes, it is your pigmentary glaucoma, in which there is reverse configuration of the iris, I would say, है ना? Normally is convex anteriorly, now it becomes convex posteriorly or concave anteriorly. So it is seen in pigmentary glaucoma, transillumination, slit defects. What is this? This can you see this part? Yes, this all, this is pseudo exfoliation. This is your pseudo exfoliation. Done. Okay, what is this? This was asked recently in your INICET exam. So can you see what are these? This is your aqueous humor pockets which are formed in the vitreous cavity. So the aqueous humor keeps on getting dumped into the vitreous cavity. As a result, it raises the pressure of the vitreous chamber, which pushes the lens forward, and as a result there is collapse of the anterior chamber and closing of the iridocorneal angle. This is known as malignant glaucoma. This is also known as inverse glaucoma. Why inverse glaucoma? Because in glaucomas you actually lower the IOP by giving parasympathomimetic, which actually leads to pupillary constriction, and it increases the iridocorneal channel so that more aqueous can go out and the IOP can be decreased. But in this particular type of glaucoma, you don't give parasympathomimetic, which is pilocarpine. You actually give atropine, which is a mydriatic agent. So you are giving ulti drug na. So that is why you call it as inverse glaucoma. It is inverse glaucoma. Yes, repeat it 3-4 times so that it gets stuck into your magnet की तरह दिमाग से चिपक जाए. Okay. Now coming out to the retina, of course, you should know about 10 layers of the retina. So in recent exam, there was a pointer which was pointed towards this layer, and it was asked which layer is this. So you need to remember this. So 10 layers. If you want an easy way to remember, you can watch my back to basics video on DAMS eMedicos app, where I have explained how to remember all the 10 layers in just 2 minutes. Yes. Okay. So this is your OCT of the macula. OCT mein you can see that there is foveal dip. So this actually depicts the fovea. Yes. Yes. What is this? This is your spot diagnosis. Spot diagnosis of what? This is your FFA. What has happened? Just a moment. So that was your FFA, which is fundus fluorescein angiography. Fundus fluorescein angiography, you take the fluorescein dye, you inject in the antecubital vein. After 11 seconds, it appears in the retina. You take multiple images with the red free light, and there is an angiogram which is created. Yes. And why it is black in the center? It is black in the center because in center there is a very dense pigment which does not allow choroidal fluorescence to pass through it. Yes. And also there is very thick ganglion cell layer. Okay. What is this? Can you appreciate spot diagnosis? What is this? So can you see that this is horseshoe shaped tear on the retina? So which detachment is this? This is rhigmatogenous retinal detachment. So which is the most common site of RRD? It is superotemporal. This is also your previous year question. Now this is which detachment? This is your exudative retinal detachment. Can you appreciate the exudates? Yes, these are all exudates. So exudative retinal detachment. Yes. And what is this? Can you see the tractional bands here? So this is your tractional retinal detachment. This is your tractional RD. What is this? So it appears, you will say, sir, it is pus in the anterior chamber. My dear friend, if there is pus in the anterior chamber, it will be present here. It is present superiorly. So it looks like a pus in the anterior chamber, which is at an inverted place. So you call it as inverse hypopyon. Inverse hypopyon is not true hypopyon. It is actually the silicon oil emulsified in the anterior chamber. Because it is lighter, it will rise up and it will get emulsified. So it is inverse hypopyon. You put silicon oil as a treatment modality in retinal detachment. Sometimes it happens to come into the anterior chamber and it rises up and it fills the superior quadrant of the eyeball, leading to inverse hypopyon. What is this? Can you appreciate the dot hemorrhage, blot hemorrhage, exudates? Can you see this? So this point toward NPDR, non-proliferative diabetic retinopathy. This is also an exudate. So there are soft exudates, hard exudates, dot blot hemorrhages. But if there is proliferation, you call it as proliferative diabetic retinopathy, that is PDR. And what is this? Can you appreciate the exudates here? Exudates. So here also there are hemorrhages, but you can see the exudates which are present at the macula. So this actually tells me that it is CME, cystoid macular edema, because there is a presence of numerous exudates at the macular region. Of course, CME has a proper definition based on at what distance, in which area exudate should be present. We are not going into that depth, but yes, this image simply is depicting the presence of exudates and cystoid macular edema. What is this spot diagnosis? This image is the same image which was asked in your recent INICET exam. So can you see these black areas? Yes, can you see these black areas? These are your retinal ischemia. So there was one option of ischemia there. So that is your retinal ischemia. And what are these hyperfluorescent areas? These hyperfluorescent areas are those of the neovascularization. Because neovascularization, new vessels are leaky vessels. So they are going to leak the fluorescein dye which will hyperfluorescence. So neovascularization. Yes. Okay. Now next is yes, macular star. So what is macular star? It is seen in hypertensive retinopathy, and you can see the exudates. So these are hard exudates which are present around the macula and they are forming a star. You call it as macular star. Okay, what is this typical image? I have given you recently in my Telegram grand INICET quiz. Yes, so this is a typical splash tomato appearance which is seen in central retinal vein occlusion. What is this? So if there is only one branch which is occluded, so there will be this splash tomato appearance, not throughout the retina. There will be hemorrhages just around the one vessel which is blocked. So probably here only the superotemporal branch is blocked. This is inferotemporal branch, this is superonasal branch, this is inferonasal branch. So there is blockage of the superotemporal branch, which is telling you that it is a case of branch retinal vein occlusion. That is our spot diagnosis. Can you appreciate the cherry red spot? Can you see the kettle tracking, which is due to presence of stagnated blood column? Can you also see that some retina is viable? This is a case of cilioretinal artery which is present in approximately 35% of the patients. Even after having central retinal arterial occlusion, the part of the retina remain viable because that is supplied by cilioretinal artery, which is actually a branch of short posterior ciliary artery. That is not a branch of central retinal artery. So this is small sort of viable retina, but yes, cherry red spot, kettle tracking due to stagnated blood column, it is seen in central retinal arterial occlusion. What is this? Can you see a typical appearance? This is known as flower petal appearance. What is this appearance? Flower petal appearance. It is seen in cystoid macular edema when you do fundus fluorescein angiography. Cystoid macular edema, fundus fluorescein angiography. Now it is also a case of cystoid macular edema. You can actually see the cyst in which layer? So in CME the cysts are present in outer plexiform layer. This is which image? This is your OCT macula image. Yes, OCT macula image. Yes. Okay, so this is a case of CME. आगे बढ़ते हुए, yes, quickly. Yes. Okay, what is this? This is your typical smokestack pattern. So smokestack pattern is seen in central serous retinopathy, but mind you, it is specific to CSR, but it is seen only in approximately 15 to 20% of the patients. But there is another pattern which is ink block pattern, which is not specific to CSR, but that is seen in 80 to 85% of the patients. What is this? Pale waxy disc, arteriolar attenuation, bony spicule, pigmentation at mid periphery. Typical. It is a case of retinitis pigmentosa. It is a condition in which there is apoptosis of rods followed by cones inside I told you apoptosis of rods, then cones. So that means rods are affected first. That also tells me that the earliest symptom of the patient will be night blindness. This is also was asked in your recent INICET exam, right? Yes. Okay. Now what is this? Egg yolk appearance of the macula. Egg yolk appearance of the macula is your best disease. So egg yolk appearance, so this is seen early in the disease and late in the disease. In best disease is scrambled egg appearance, जैसे अंडे की भुर्जी होता है, scrambled egg appearance, and this gives an appearance of pseudo hypopyon. This gives an appearance of pseudo hypopyon. Yes, pseudo hypopyon. Okay. What is this? Spot diagnosis. Hint मैंने नीचे दे दिया, थोड़ा सा difficult था. तो can you see that there is break in the Brooks membrane? Yes, and there are diseases which are associated with this. How will you remember? Pepsi, pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget's disease of bone, sickle cell anemia, and incontinentia pigmentatis. So yes, you are right. I am talking of angioid streaks. I am talking of angioid streaks. Okay. All right. And what is this? So this is a history which I have provided. There is telangiectasia, exudates, and the child is young, approximately 7 years of age. So it is, this disease is seen in first decade of life, and that is your Coats disease. And Coats disease is a very nice differential diagnosis of retinoblastoma, because in Coats disease you are also going to see leukocoria. Leukocoria is seen. Yes. Okay. What is this? You can see retinoblastoma because retinoblastoma is a calcified tumor. You can see retinoblastoma because it is a calcified tumor. You can also see calcification here, which is a pinealoblastoma, pineal body tumor. So it is forming a triangle. You call it as trilateral retinoblastoma. So what is trilateral retinoblastoma? Bilateral retinoblastoma with pinealoblastoma. Okay. Now coming over to the next chapter, which is chapter 6, neuro-ophthalmology. Now what is this? So you project the light in one eye, both pupil are getting constricted. You project the light in the other eye, both pupil are dilated. So this is a typical case of RAPD, which is Marcus gun pupil, which is due to damage to the afferent pathway. So here the left eye afferent pathway is damaged. You shine the light in the right eye, so both pupil will constrict. The moment you shift the light from the right eye to the left eye, so because of the removal of the stimulus from the right eye, because left eye's optic nerve is not able to take the impulse from the retina to the pretectal nucleus, Edinger-Westphal nucleus, means it is not able to form the pupillary light reflex. So both pupil will dilate. So this is seen in Marcus gun pupil or relative afferent pupillary defect. So this is Marcus gun pupil. Yes. Okay. What is this? So you are showing the light, there is no reaction. You are asking the patient to accommodate, so pupil is getting constricted, and it is bilateral myotic pupils. So what is this? This is your typical Argyll-Robertson pupil. Argyll-Robertson pupil, the light reflex is absent, but the accommodation reflex is present, and the pupil are bilateral and constricted pupils. What is this? So here also light reflex is absent, but accommodation reflex is present. But did you notice one thing? The pupil is unilateral and dilated. So this is one pupil, that is, yes, Addy's pupil, Homi-Addy's pupil. So that is the difference between Argyll-Robertson pupil and Addy's pupil. Okay. So can you appreciate? Can you tell me the spot diagnosis? I'm going to give you a hint. So this is your chalky white optic disc. It is, yes, it is optic atrophy. Which optic atrophy? This is your primary optic atrophy. Primary optic atrophy, in which you see chalky white disc, and here you see the dirty gray disc with non-defined margins. This is your secondary optic atrophy. Why is it so? Because this secondary optic atrophy follows after papilledema, after disc edema. So that is why. Yes. And what is this? If I am talking of disc edema, what is this sign? Can you see the stretch lines in the retina? Are you able to appreciate the stretch lines in the retina? This is known as Patton's lines. Yes, Patton's lines. And now there was a recent exam question in which it was asked, in which condition there is enlargement of blind spot in papilledema. There is enlargement of blind spot on perimetry. Yes, this is your recent exam question, just 5 months, just 6 months back. Okay. All right. And moving over to the next part. Okay, again this is papilledema. You can appreciate the peripapillary hemorrhages. You can also see champagne cork appearance, champagne cork appearance of the optic nerve head. Okay, now can you tell me the diagnosis? क्या ये diagnosis बता पाएंगे? What is the diagnosis? Here you can see that there is not full ptosis, there is partial ptosis. There is pupil which is constricted. Yes, so partial ptosis means there is of course involvement of which muscle, if you are able to now connect the dots along with constricted pupil. So that is your Muller's muscle, whose supply is sympathetic supply. Then there is what? There is meiosis, and there is also enophthalmos. Enophthalmos means it appears as if the eyeball has sunk in due to partial ptosis when actually it hasn't. So this enophthalmos is not true enophthalmos, this is pseudo enophthalmos. Along with it there is anhidrosis. Anhidrosis is loss of sweating and collectively is known as Horner syndrome. Now if the examiner asked you which of the following is seen in Horner syndrome except ptosis, enophthalmos, anhidrosis, meiosis, so you will mark enophthalmos because this is not true enophthalmos, this is pseudo enophthalmos. Now if the options are changed, now the options are mydriasis, enophthalmos, anhidrosis and ptosis, then because mydriasis is entirely of the opposite of meiosis, so you will mark mydriasis in this case. Okay, so what is this? So this is your bilateral superiotemporal quadrantopia, which is the earliest visual field defect that you see in pituitary adenoma. Pituitary adenoma. So adenoma is when it is large, you call it as macroadenoma, which is more than equal to at least 1 centimeter. That is the earliest feature that you see. Okay, what is your spot diagnosis? You are asking the patient to look onto the right side, both eyes are going right. When you ask the patient to look onto the left side, so one eye does not go on the left side but other eye goes. So this is internuclear ophthalmoplegia, and this is due to damage to medial longitudinal fasciculus. So in this eye, medial longitudinal fasciculus is damaged. Now because one eye is not moving inside but other eye is moving outside, so there will be a condition in which there will be two images which will be formed in the two eyes. So voluntarily you are trying to move the eyeball here, but the eyeball is not going, but this eye has gone here. So involuntarily the brain will try to undo the diplopia by bringing the other eye, the gone eye which is outside, to the center. So there will be ipsilateral abduction defect with contralateral horizontal nystagmus. Ipsilateral adduction. Adduction means it is not going on the inside. Ipsilateral adduction defect with contralateral horizontal nystagmus. That is your internuclear ophthalmoplegia. Now coming over to the next chapter, which is that of squint. So what is this? So these tests are known as stereo tests. They test actually your three-dimensional visual acuity. These are stereo tests. So titmus fly test. So you give a fly image to the patient and the patient will try to touch the wings of the patient. If the three-dimensional vision is there, the wings will appear to be slightly above the base of the card. So the patient will keep on hovering his finger in the just above the card, while if the patient's three-dimensional vision is absent, the patient is actually going to touch the wings of the fly. So that is your titmus fly test. This is also your previous year image asked in INICET exam. Then this is your circle test. Out of a set of 4 circles, 1 circle will appear above the base. So this is animal test. Out of the 5 set of animals, 1 animal will appear to be above the base. So there are other tests: Ren.E test, TNO test, Frisbee test and Lang test. Yes, these are all your stereo tests. What is this? This is your Maddox rod test. So Maddox rod, so there is horizontal group of cylinders which convert the light which is coming from front into a vertical line. Yes, so can you tell me what is this? Why it is exotropia or phoria? So if there is option of exotropia, exophoria, tropia is better because phoria is latent squint, tropia is manifest squint. So this is a case of right exotropia. So this is the patient's view. This is patient's view. That is what I want all of you to let know. This is patient's view. So patient's view, if you have placed the horizontal group of cylinders in front of the right eye, so if there is right exotropia, so that means if the eyeball has turned outside, so instead of fovea being stimulated, now the temporal retina is going to be stimulated. Yes, but the temporal retina interprets the nasal visual field. So temporal retina will shift the vertical line which is formed due to placement of the horizontal group of cylinders, which is Maddox rod, in front of the right eye. It is going to shift that vertical line onto the nasal side. So ultimately what the patient is going to see, the patient is going to see the torchlight which is central, coming from the center, and the vertical line which is shift onto the other side, onto the left side. So this is your exotropia. Similar is the case of esotropia. If the eyeball has turned inside, instead of fovea, now the nasal retina is being stimulated, but the nasal retina interprets the vision from the temporal field, and as a result the patient is going to see the torch light from the left eye, and the vertical line which ideally should cut the torch light will now be shifted onto the right side, onto the right side. So this is your left side, and this is the right eye image, and this is also the right eye image which is now shifted to the right side. Yes, I hope you have understood. The same thing applies to Worth 4 dot test, and the same Worth 4 dot test was asked in your recent exam. I'm sure that you know that red filter is placed in front of right eye, green filter is placed in front of left eye. If the patient is having suppression, let's suppose red and green filters are placed and the patient is shown the Worth 4 dot test in which 2 green dots, 1 red dot and 1 white dot is there. Yes, now the red filter is going to convert the white dot into red dot. I'm going to explain. Wait, so these are 2 green dots. Yes, G, and there is 1 red dot, and then there is 1 white dot, and the right eye is made to wear red filter, left eye is made to wear green filter. Now if the patient is having fusion and the patient is not having diplopia, so what the patient is going to see, patient is going to see 2 green dots, 1 red dot, and this one will be orange or red green. Yes, orange or red green. Why red green? Because of superimposition of the white dot which will be converted to green via left eye because of the placement of the green filter. It will be converted to red via right eye due to placement of the red filter. So net and net patient is going to see this in red green color or orange color. Yes, but what if the patient is having right eye suppression? That means the patient's brain is not accepting the image provided by the right eye. So in that case the patient is going to see 3 green dots. So this was asked in your recent INICET exam. What if the patient is having left eye suppression? So that means the patient is going to see 2 red dots. 2 red dots because the brain is not accepting the left eye image now. So 3 green dots will not be seen. Okay, now what is this? This is Hess screen. It is seen in cases of, this test is done in cases of paralytic squint. So one eye will have very less movement and another eye will have very high movement, very large movement. So this is probably your paretic eye and this is your overacting eye. Overaction is due to the law and the name of the law is Hering's law. Yes, and what is this? This is also important. So see, this is esotropia, hai na? This is esotropia. The eyeball has moved inside. When the eyeball has moved inside, the fovea has gone outside. This is the nasal retina which is being stimulated. When the nasal retina is being stimulated, it is going to project the image onto the temporal field. So the false image will be on the temporal field of the left eye. The same concept which I told you while discussing Maddox rod test. So this projection of the image is on the same side now, because there is left esotropia and the false image is also forming on the left side. So you call it as uncrossed diplopia. It is seen in esotropias. Had it been exotropia, easiest ways to remember is in exo there is X na, so there will be crossed diplopia. There will be crossed diplopia. Done? Okay. Now next is, what is this? This is optokinetic nystagmus, checking on for the physiological status of the eyes in terms with nystagmus. So there are black and white drums, you rotate it, so there will be nystagmus of the eyes of the patient. Optokinetic nystagmus drum. This can be asked in a image based format. Okay, now what is this? So you can see the central shiny thing, hai na? So spot diagnosis, while around you can see that there is, what is this? So there is this scarring, probably after the corneal ulcer, and you can see the central shiny thing. This is your descemetocele. Descemet's layer was regarded as the strongest layer of the cornea before the discovery of Dua's layer. Now, if Descemet's layer is there in the option, Dua's layer in the option, you will mark Dua's layer. So descemetocele is when there is bulging of the Descemet's membrane. What is this? So this is your staphyloma. Which staphyloma? Can you tell me? This is your ciliary staphyloma. Don't confuse ciliary staphyloma with that too. Scleromalacia perforans. Scleromalacia perforans is when there is just the flattening of the, just the thinning of the sclera, through which you will see the ciliary body, which will be pigmented like this. But here you can see the bulge. If there is bulge, you will call it as staphyloma. If there is just the thinning, as you see in rheumatoid arthritis, as you see in autoimmune diseases, that you call it as scleromalacia perforans. That is the one important point by which you can differentiate between staphyloma and scleromalacia perforans. In so I'll just write scleromalacia perforans. So there is just thinning of the sclera. Here there is bulging and thinning. Yes, okay. Now what is this? Spot diagnosis. Can you appreciate the hypopyon? Can you appreciate the satellite lesions? Can you appreciate the fluffy margins? Of course, there is also dry looking ulcer which may not be appreciated in the image. So this is a case of fungal corneal ulcer, which is fungal keratitis. Okay, what is this? Can you appreciate the knobbed ends? So this is a typical case of dendrites. So dendrites are seen in herpes simplex virus keratitis. Now here you cannot see the knobbed ends. So this is a case of pseudodendrites. Pseudodendrites are seen in herpes zoster ophthalmicus, and you can typically see a sign. What is this sign? This is your Hutchinson sign. This is your Hutchinson sign, and it is seen in herpes zoster ophthalmicus. Please understand, herpes simplex virus is different from herpes zoster ophthalmicus. Herpes zoster ophthalmicus is actually varicella zoster virus, which is chickenpox virus. Yes. And Hutchinson sign is when there is involvement of the tip of the nose. The corneal involvement is inevitable. What is this? Can you see the ring-like ulcer? Okay, ring-like ulcer. So this is typically which keratitis? Acanthamoeba keratitis. And do you know that this keratitis is very, very painful? Why? Because it leads to inflammation of the nerves. Subepithelial nerves are inflamed. Yes, it causes perineuritis. So it is very painful, and it is the most common cause of corneal ulcer in contact lens wearers who have a history of swimming in pond after wearing contact lenses, or who have a history of washing contact lenses with tap water. Otherwise, overall, most common organism associated with contact lens keratitis is Pseudomonas. It is not Acanthamoeba. Here we have a condition. Condition is swimming in pond or washing contact lenses with tap water. Yes, and you can appreciate that this is a ring ulcer, and you will see ring ulcer, you will say, okay, it is okayish, there is central clearing, so the patient will be relatively comfortable. No, symptoms are more than signs. It is very painful because of the involvement of the subepithelial nerves. While when you will see the fungal keratitis ulcer, so it will appear that the patient will be in so much of pain, satellite lesion, hypopyon will be non-sterile and it will be fixed. Yes, and you will you will feel that the patient must be in so much of pain, but the patient will be relatively stable. So signs are more than symptoms in fungal keratitis. Here symptoms are more than signs. Okay, so what is this? What is this? So you can see the stretch marks in the Descemet's membrane, and it is seen in keratoconus, and this is known as Vogg's striae. Vogg's striae, V for Vogg's, V for vertical stretch marks, and it is seen in which condition? Keratoconus. Yes, This is also your previous year question. In keratoconus as well, you see a particular ring. So remember KF ring is copper deposition in Descemet's membrane. Here it is Fleischer ring, which is your iron deposition, on the epithelium of the cornea. What is this sign? So this sign is a typical sign, that is your Munson sign. It is seen in keratoconus. You ask the patient to look down and the lower lid will attain a V-shaped formation. Okay, so what is this? It is evident. So you can see that there is superficial corneal neovascularization. How will you differentiate between superficial corneal neovascularization and deep corneal neovascularization? Superficial will be in continuity with the conjunctival vessels, and you will be able to trace it from the limbus towards the cornea or from the limbus towards the conjunctiva. While in deep corneal neovascularization, you will not be able to trace. Here you will see that there are a lot of branching, but in deep corneal neovascularization, the branches will not be present. It will be relatively straight. Okay, what is this? This is the keratoplasty which is done. So the question was, which sutures are applied? So 10O nylon sutures are applied. These are watertight sutures, 16:24. So in cornea you apply 10O nylon sutures. Okay, what is this? So this is your corneal prosthesis. So this is known as Boston K Pro prosthesis. Boston K Pro prosthesis. Okay, and what is this? So this is radial keratotomy which is done. You can actually see this is my real patient. So radial keratotomy done, but the question which was asked in your INICET exam is, it is absolutely contraindicated in which patients? Boxers, because post radial keratotomy it leads to thinning of the cornea, and even a single punch can lead to corneal rupture. So that is absolutely contraindicated. But if I talk about LASIK, LASIK is relatively contraindicated, in boxer. In LASIK you remove the flap and you ablate the central part of the cornea and you replace it if you want to correct the myopia. Yes, and if you want to correct the hypermetropia, you ablate the peripheral part of the stroma of the cornea. Yes. Okay, now coming over to the conjunctiva. So this is pink eye epidemic keratoconjunctivitis, your previous year question. The most common organism is your adenovirus. This is also known as eye flu. It is very common during the change of season from winters to summer. So this is eye flu. And can you see the subconjunctival hemorrhage? This is subconjunctival hemorrhagic conjunctivitis. You also call it as acute hemorrhagic conjunctivitis, and acute hemorrhagic conjunctivitis can be caused by a group of virus which is picoRNA virus, and under picoRNA virus, so there is one enterovirus 70. This is your previous year question, enterovirus 70, and Coxsackie A24. So if one option is there, you are going to mark enterovirus 70, which is overall the most common cause of acute hemorrhagic conjunctivitis. This is Coxsackie A24. Okay, अरे कहाँ गया? ओहो, ऊपर पहुंच गया हम बहुत. All right, now coming over to the next image. Okay, so this is Herbert Pitt. So Herbert Pitt, these are the scars which are present at the limbus. Can you tell me in which disease Herbert Pitts are seen? Yes. So it is seen in trachoma, Herbert Pitts. Okay, these are actually the scars which are left by the bulbar follicles. This is trichiasis. What is trichiasis? Misdirected eyelashes. This is also a single term which can be asked. There is thickened tarsal plate, you call it as tylosis. So all these are seen in trachoma. So all these features are seen in your trachoma. Even entropion, it is seen in trachoma. Entropion is inward rolling of the eyelid. And I was telling you na, Art's triangle. Now comes the Art's line. Art's line is fibrotic scar present on the upper palpebral conjunctiva in trachoma. So Art's line. Now you can appreciate the limbal mucoid nodules with Horner Tranta dots. These are seen in vernal keratoconjunctivitis, which is an allergic condition. It is most common in males who are teenagers, and it is type 1+4 hypersensitivity reaction. If it is not there, mark only type 1. If it is not there, mark only type 4. And what are these? Typical cobblestone papillae. These are your cobblestone papillae. Don't confuse cobblestone papillary with that of giant papillary conjunctivitis, although both of them may look same, but you need to go through the history. Giant papillary conjunctivitis is more commonly associated with contact lens users. Here there will be a male which will be teenager, but there can be male or female, it can be adults with a specific history of wearing contact lenses. This is typical Shields ulcer. Shields ulcer is also seen in vernal keratoconjunctivitis. So what is this, boys and girls? This is your pterygium. Pterygium is elastotic degeneration of conjunctiva. Pterygium is elastotic degeneration of conjunctiva, and there is one line which you see in pterygium. The name of that line is your Stocker's line. What is that Stocker's line? Stocker's line is the deposition of the iron on the corneal epithelium. Yes, wait, I'll just scroll it down. Just give me a second. Yes, we are almost there. Okay. Yes, now, so this is your Stocker's line. So it is present on the iron is present on the corneal epithelium. Yes, so corneal epithelium, there is iron deposition also in keratoconus, which is at the base of the cone. You call it as, yes, Fleischer ring, है ना? Here we are talking of Stocker's line. What is this? This is a triangular yellowish white patch which is protruded. Yes, so this is your pinguicula. Some doctors consider pinguicula as a precursor of pterygium. Yes, one question which I want to tell here is, what is the treatment for pterygium? So one surgery is your Bayer sclera technique, but Bayer sclera technique has a very high recurrence rate which is up to 80%. So 80% recurrence rate of Bayer sclera technique. So we came up with another technique, which is you remove the pterygium, you put a autograft, the graft of conjunctiva taken from the same eye. You call it as perfect surgery, pterygium extended resection followed by extended conjunctival transplant or conjunctival autograft. I'm not writing this much, this is just for you to know because this can be asked. Okay, and perfect surgery has a recurrence rate of just 0.01%. Okay, now what do you see here? This is also your previous year INICET question. Which test? Epinephrine test, because we are talking of episcleritis. So when you will put a drop of epinephrine on the eyeball, it is going to blanch the superficial vessels and this will be blanched, and this is known as epinephrine test. Okay, now yes, this is what? This is your limbal dermoid. Limbal dermoid. Can you tell me which is the most common location of limbal dermoid? It is inferotemporal. Inferotemporal. Don't confuse limbal dermoid with that of dermolipoma. Dermolipoma is present. Dermolipoma is present at the fornix. This is present at the limbus, and it may even be associated with hair, which was the image asked in your recent exam INICET question just 5 months back. Okay, all right, now coming on to ocular adnexa. So you can see that there is absent lid crease, which makes you think of the diagnosis of which ptosis? Congenital ptosis. Yes, there is typical absent lid crease, and this is your margin reflex distance. You show the light, you measure the distance of the center of the upper eyelid and the corneal center light reflex. So this is margin reflex distance. Okay, which surgery do? You go on for frontalis brosling surgery if it is a case of moderate and severe congenital ptosis, and also Marcus Gunn Joving syndrome. You go for Fasanella Servet procedure if it is congenital ptosis which is mild, and also acquired ptosis, because acquired ptosis will be mild ptosis with good levator function. And which is this procedure? This procedure is done for entropion, and the name of this procedure is Jones procedure. You give an incision here, then you tightly suture it. It is going to pull the inward rotated eyelid anteriorly, है ना? So this is entropion, and which is this procedure? This is your Bix procedure. You actually cut a part of the lower eyelid and suture it tightly so that there is a stretch which is developed and the eyelid is rotated outside. This is big procedure. And this is which surgery? You do V and you convert it into Y. This is VY operation which is done for ectropion. And this is which procedure? Can you see the formation of Z? This is your Z plasty. This is your Z plasty. What is this? So this is a sty which is present at the typical lid margin. Don't confuse it with chalazion, which is present away from the lid margin. This is present at the lid margin and it is very painful, and it is inflammation of hair follicle. And if hair follicle is not in the option, you can go for gland of Zeiss. And here you can see the swelling which is lying away from the lid margin. It will be chronic, while sty will be acute and painful. It will be chronic and non-tender. Yes. And what will be the treatment of sty? You will give antibiotic, oral NSAIDs you can give. You can even give antibiotic eye ointment. Don't go for antibiotic eye drops. I still remember I was taking a class in Delhi and I had just taught sty, and when I took a break I saw a student putting antibiotic eye drops. मैंने कहा भाई antibiotic eye drop क्यों डाल रहे हो? सर स्टाई हो गया. मैं कहा गुरुजी अभी 1 घंटा पहले तो हमने करा है कि इसमें ऑइंटमेंट की जरूरत है, क्योंकि एंटीबायोटिक आई ड्रॉप विल एक्चुअली गो ऑन द surface of the eye. There is no problem on the ocular surface. The problem is there in the eyelid. No. So I asked that person to quickly go and take one ciprofloxacin eye ointment and then start applying. Yes, and throw that eye drop in a dustbin. Okay, so chalazion is a condition in which there is blockage of the duct of the meibomian gland. So this is non-tender swelling and it lies away from the lid margin. And what will be the treatment? Treatment is IND, incision and drainage. You can also give intralesional steroid injection, but IND is a pretty decent, reliable method of treating chalazion. Okay, what is the refractive error? The image is formed in front of the retina. This is also your previous INICET image based question. So it is myopia. Myopia is when the image is formed in front of the retina while accommodation is at rest. So this is behind retina. This is your hypermetropia. And Stump's conoid, this was also one of the images which was asked in your recent INICET exam question. So you can see that there is different point of focus. Yes, so it actually depicts about the astigmatic refractive error in this image. Yes. Okay, now coming over to the last image, and this image is that of your retinoscope. Retinoscope is the method by which you can assess the refractive error objectively. Objective assessment of the refractive error. You don't depend on the patient to speak. If the patient speaks, like you are asking the patient to read Snellen's chart, you change the glasses and you ask the patient, now you are able to see, now you are able to read, tell me. So you are dependent upon the patient now. So that is subjective method of refractive error correction. This is objective method of refractive error correction. So boys and girls, so this was all about the image discussion. I am sure that you are going to find this video very, very helpful in the coming times during your PG entrance exam. Any doubts, any queries, you can get back to me on WhatsApp. You can let me know by sharing your queries, and your feedback will be much appreciated. So I have recently started with my YouTube channel, and you can also follow me on Instagram, which is I_Manish, Manish, yes. And you can also follow me on Telegram, and I'll be very happy to have you. And yes, I wish you all the very best, and rise and shine. And what else? Nothing, just okay. Bye bye.